Inflammatory bowel disease is an umbrella term encompassing two primary conditions, ulcerative colitis and Crohn's disease. The main principle underlying these diseases is that they cause inflammation of the digestive tract. This inflammation leads to abdominal pain and diarrhea and is autoimmune in nature, meaning the body mistakenly attacks its own gastrointestinal system, causing inflammation and symptoms. While these diseases share similarities, they also have significant differences. We will discuss the main signs and symptoms of ulcerative colitis and Crohn's disease, their characteristics, risks, treatment options, and how to differentiate one from the other. Ulcerative colitis. The most common symptom of ulcerative colitis is bloody diarrhea, especially in younger patients. Chronic bloody diarrhea is a hallmark of this disease. The inflammation in the colon leads to bleeding and disrupts water absorption, resulting in frequent, bloody stools. Pain is the second most common symptom, typically occurring in the lower left part of the abdomen. This is because the inflammation usually affects the rectum and sigmoid colon, which are located in the lower left quadrant of the abdomen. Thus, the combination of bloody diarrhea and lower left abdominal pain can be considered characteristic of ulcerative colitis. Additionally, ulcerative colitis typically involves only the lower part of the intestines, the rectum and colon, without affecting the entire intestine. Patients with ulcerative colitis often experience urgency to defecate, and pain may sometimes subside after a bowel movement. Weight loss and fatigue can also occur due to nutritional loss from diarrhea, absorption problems, and decreased appetite. Crohn's disease. Crohn's disease, in contrast, can cause inflammation anywhere in the gastrointestinal tract, from the mouth to the anus. This is a key difference from ulcerative colitis, where inflammation is restricted to the large bowel. Another distinct feature of Crohn's disease is the presence of skip lesions, areas of inflamed tissue interspersed with normal, unaffected regions. This alternation of inflamed and normal sections contrasts with the continuous inflammation seen in ulcerative colitis, which is localized in the lower part of the large intestine. A third critical difference is the depth of inflammation. In Crohn's disease, inflammation penetrates deep into the bowel wall, transmural, affecting the entire thickness of the bowel. In contrast, the inflammation in ulcerative colitis is superficial, affecting only the inner lining of the colon. Crohn's disease can be more comprehensive, widespread, and deep. The alternation of thickened, nodular inflamed areas with normal regions gives the intestines a cobblestone appearance on imaging studies like X-rays with barium contrast and CT scans. There are no very classical symptoms for Crohn's disease since it can affect any part of the gastrointestinal tract, but the most common scenario is lower right abdominal pain due to inflammation of the terminal ileum. Diarrhea is also a common sign, though bloody diarrhea is not typically a characteristic feature, especially in the early stages of the disease. However, bloody diarrhea can occur later. Weight loss, fatigue, and sometimes fever may also occur due to inflammation or secondary infection. Common features. Both diseases have periods of active flare-ups and remission, during which symptoms may subside. Active flare-ups can last from several days to weeks, followed by remission periods. Various factors, including infections, stress, and dietary changes, can trigger flare-ups. Long-term risks of ulcerative colitis and Crohn's disease. Ulcerative colitis. For ulcerative colitis, the chronic inflammation significantly increases the risk of colorectal cancer, making regular screening essential for early detection. Additionally, ulcerative colitis can lead to a condition called toxic megacolon, where the colon becomes severely enlarged and dilated, potentially resulting in rupture. This is a medical emergency. Due to its autoimmune nature, ulcerative colitis can also affect other parts of the body. For example, it can involve the liver, leading to a condition called primary sclerosing cholangitis. It may also impact the skin and joints. Serious bleeding can occur due to damage to blood vessels caused by inflammation. However, with appropriate treatment and surgery, if necessary, most patients can achieve long-term remission. Crohn's disease. Because Crohn's disease affects the entire thickness of the bowel wall, its complications are more varied and severe. Long-term risks include fistulas. Abnormal connections can form between the intestines and other organs, such as the bladder or skin. Abscesses. These are localized collections of pus within the abdominal cavity or bowel wall, usually due to secondary infection. Strictures, chronic inflammation and scar formation can lead to narrowing of the bowel, which may cause bowel obstruction. Perianal disease, this includes fissures, abscesses, and fistulas around the anus, leading to pain and discharge of pus, blood, or stool from abnormal openings in the perianal region. Many patients with Crohn's disease require multiple surgeries over their lifetime to manage complications like strictures, abscesses, or fistulas. The disease can be unpredictable, with some patients experiencing frequent complications and others maintaining long periods of remission. Diagnosis. Ulcerative colitis. Diagnosis is based on symptoms, signs, and endoscopic findings. Continuous inflammation starting from the rectum and extending proximally is a characteristic feature. Crohn's disease. Diagnosis involves assessing symptoms and colonoscopy findings. Key features include patchy areas of inflammation, skip lesions, deep ulcers, and a cobblestone appearance. Crohn's disease can involve any part of the gastrointestinal, GI, tract. During a biopsy, the presence of inflammation and granulomas, a type of tissue inflammation, is characteristic of Crohn's disease. Treatment. Ulcerative colitis. First-line treatment, aminosalicylates, such as mesalamine or sulfasalazine, are commonly used. Corticosteroids, used for short-term management during acute flare-ups, for example, prednisone. Supplements, calcium, vitamin D, folate, and iron are often recommended to treat anemia and for patients on sulfasalazine. Diet. A low-fat, non-spicy diet with low dietary fiber during active periods is beneficial. Crohn's disease. First-line treatment, corticosteroids, particularly budesonide, are preferred due to fewer systemic effects. Aminosalicylates are sometimes used but are less effective. Supplements. Vitamin B12 supplementation is important, especially for those who have undergone ileum resection surgery due to decreased absorption of the vitamin. Calcium and vitamin D are also important. Depending on specific deficiencies, supplements like zinc, folate, or magnesium may be needed. Dietary recommendations for both conditions. During active periods, low-residue foods are recommended to reduce bowel activity and irritation. These include refined grains, white bread, white rice, and refined cereals. Cooked vegetables, without skins or seeds, such as carrots and potatoes without skins. Fruits, without skins or seeds and in moderation, such as bananas and melon. Tender, well-cooked meats, poultry and fish. Dairy products, if tolerated.